So good evening, friends. Welcome to this Tuesday evening academic programs from Yashoda Group of Hospitals. We have been bringing these updates, interactive sessions, and interesting areas of interest from all the clinicians across India. And we are happy and proud to say that this has been almost 2 years since we initiated this program, and it is going on well. And we see a lot of interest across the India and globe. So today we felt in the last couple of weeks or so, there were a lot of hue and cry about a sudden surge of COVID cases in Southeast Asia, particularly in China, where there is actually drop down of those zero COVID tolerance, and now there is an open acceptance to everything. So that created a lot of questions in the minds of not just the clinicians, in the families and relatives. So we tend to get a lot of queries across. Yes, we know there can be a lot of uncertainties. We know there can be lots of ifs and buts. But at this point of time, with current knowledge and the current updates, what we'll try to bring is Dr. Kaladhar, who is our consultant and head of the department from critical care in Malakpet, will bring us a review across. And we have a privilege and honor to have Dr. Raman Gangakhedkar sir, who has been the former chief of ICMR and also been an expert panel member of WHO to actually evaluate the origin of COVID in the recent times. So he has been an epidemiologist, he has been a scientist, he has been a person who has shown his wisdom, his guidances across India, and he has been a part of a lot of scientific debates and scientific activities and a part of ICMR during this unprecedented pandemic time, guiding, helping all of us. We welcome you, Dr. Raman sir, and it is an honor to have you on board, sir.
Thank you.
So we will go with Dr. Kaladhar, who will brief us through in next 20 minutes about what are we going through, why are we here, why are we discussing again after a gap of 1 year. Over to you, Dr. Kaladhar.
Thank you, Venkat sir. Thank you, Dr. Raman sir, for joining us as an expert panelist. So good evening all. So with this, I will start my presentation. So we will go through, yeah. Is it visible, sir?
Yeah.
Yes.
So we will start from the introduction that includes how the COVID started and what is the a brief period. Yeah, everybody knows it started in the part of Wuhan city in China, 2019 around December. Before that, the cases, even the speculation that they started before that, even itself like November and October. Then slowly it spread across to different parts of the world, Italy and then India. So we witnessed almost 3 waves. 3 strong waves. The second wave was very strongest, and third wave bit better. So from this on, I will go. What is the current situation? What is happening across the world, and is it how it will be relevant to us, and what are the strategies that we have to form to tackle the COVID crisis? So if you look at this map, so the world map, where especially the cases where they are more. If you look at the China, of course, the China, there is a huge gap in data sharing from China. But this is what it's showing from Johns Hopkins University. The map shows that the case load is much more here in China. And adjacent countries like Japan, Taiwan, South Korea, Hong Kong, they are also suffered a lot. Along with that, here and there, like in if you look at the South America, especially Brazil, Mexico, in parts of North America, which is not, this is the current situation. North America right now, the cases are slowly going down. If you look at this data, which is from Worldometer, basically the previous day, the Japan is suffering worstly, where you can see the number of cases is almost near to 2 lakhs. But deaths surprisingly are not more. They are like around 407. So that means the severity may be less. That's what I assume. So probably, and if you look at the United States of America, the cases have come down in between. In the mid part of the December, they were more. And if you look at the France, in especially the Europe countries, the Germany is more affected. The number of cases are more. And if you look at Japan, which is adjacent to the China, there also the cases are almost nearing to 1 lakh. So this is the previous data. And now the Japan is worst affected, almost nearing to 2 lakhs. And other parts like Taiwan, which is a small country, 23,000, I feel is still more for that country. So this is what happening. If you look at the western part of the world, especially the United States, where I compared between the October and December part, in the October, almost the cases came down near to 2,000. And in the mid part of the December, the cases were 1,35,000. Now they are less. Just now the previous data, as I was telling. And in Brazil, if you look at around 5th November, sorry, the slides are going. 5th November 2020, almost the cases, new cases, 7-day average, there were around 4,000 as compared to the 14th December, where it is almost near to 50,000. And Japan, as I was telling, the 8th January, almost it reached to new cases now 1,90,000 as compared to previous cases around 20,000. And even South Korea is also new cases around 20,000, 7-day average is around 60,000. So these are the different parts of the world where right now the COVID pandemic is going on with affected severely. And this article, which came in Times of India, stated that the China is fudging its COVID data. Everybody knows across the world, everybody that debate, like everybody discussing this, what going on. But the scenario, the videos which have come out have shown that the people are suffering and there is a lot of waiting time outside the hospital. The people, they are there in the wheelchairs and even on the stretchers and all. So this company which forecasted the COVID wave, probably in the January 13th, it will peak and then it will descend, and then they are suspecting possibility of the COVID wave again going up in the mid part of the March or April. So this is what. So what are the different causes that the China's data is not coming? If you look at the Chinese deaths, it stayed around 5,200, stayed there. So the reasons for that, whether really the China is suffering or not, what are the different things that we have to look at to know that the China is really suffering with severe COVID? So there are different public obituaries, which are like the celebrities, they are circulating online. And Henan province, they got affected almost 88 million, which is an unofficial record, which this company got the report. And there are the instructions to the Chinese doctors that it should not be, the COVID death should not be reported as COVID, rather it is acute respiratory failure. If the patient is having severe comorbids, probably you attribute the cause to the comorbids rather than attributing to the COVID death, so that it will not be projected a lot. And another, the indirect reason what the projection is probably more is Indian generic drugs. There is an article which shows that there is a online Indian generic drugs, the demand is very high, especially the Paxlovid and Molnupiravir, which is very high demand. It's going on in China right now. The hospitals are full and funeral homes are working overtime. This is also an indirect indication that China is suffering with a lot of COVID crisis. So there are across different social media that they say that the different strains, we will discuss about the strains of XBB 1.5 and BF7. They call, especially XBB 1.5, they call it as Kraken. Kraken is nothing but a sea monster which can destroy and spread very rapidly and destroy the ships and large ships also. So like that, because it's rapidly transmitting, they had given the name. One of the doctor, I think from University of North Carolina somewhere. So if you look at the family tree of COVID, so how the variants have appeared. If you look at initially it is like beta, delta, and then Omicron has come from there, BA2. It has then sublineage, it has become like the genetic change, makeup change, and it has become now XBB and then XBB 1.5. So it became a Omicron subvariant basically. So it descended from XBB and a hybrid of two Omicron BA2 descendants. So why this is a lot of concern? Because most of the Omicron variants right now, what are there, they are getting replaced by this XBB 1.5. So almost initially around October, the 1.5 was around 2-3%. Now across US, the cases have gone up to 40% of the cases. So almost it has spread to almost 25 countries as the data shared by the WHO. And it is exponentially growing, and the variant is likely to probably spread across to different countries. And the reason for it binds very tightly to the receptors. As we all know that the receptors most commonly attaches is ACE2 receptors. So it is having a avid binding capability to attach to those receptors, which may cause the infection spread across, and at the same time causing the infection rate is more. So this is US CDC, which shows the new year and new variant, whatever the offshoot of Omicron called XBB 1.55. As this modeling shows, from 3rd December to 6th January, it is almost gone up to 28%, and other data showing up to 40%. So this is about XBB 1.5. So what is BF7 variant? It's a sublineage of same Omicron BF5. That is BA2, it is BF5. And it is also having a strongest infection ability, and is very high transmissible. So it is right now, actually, the BF7 variant is right now there in China that is causing more infections. So surprisingly, the R value quoted across different studies is 10 to 18.6. That means it can, one person who gets infected with BF7 variant can transmit infection across to different 10 to 18 people, which is a very high R value as compared to the previous the variants. So do these people have as it was circulated among the WhatsApp groups and other media, like they have different types of like the symptoms as compared to previous variants entirely different, but it's not like that. So the symptoms are almost similar like previous variants, where the person will suffer with fever, cough, sore throat, and it can vary from mild illness to severe respiratory failure and leading to multi-organ dysfunction, severe ARDS, and so on. So which is more dangerous? So this is still uncertain, basically. But XBB 1.5 as compared to BF7, probably speculation is XBB 1.5 is a bit more dangerous compared to BF7 because it evades immune defenses as gained from vaccination or prior infection. It can evade, and that is the reason it can spread faster than BF7. So what the symptoms, as I was telling, XBB 1.5 and even BF7, they produce the same types of symptoms as compared to the previous variants. So with this background, whether this should be a concern to India situation, should we be all alarmed by the COVID surge which is happening across the world, probably which is the China, which is close proximity to our country? Should we all be alarmed? If we look at the current situation in India, almost 3 weeks when we alerted ourselves, we have shown we were vigilant that this surge is happening across China. We should be vigilant. So if you compare from 3 weeks up to now, there is no sign of any uptick in infections. That means the infections are not going up. So if you look at the graph, the Omicron third wave, where it almost ended around early part of the March, the graph shows almost it is flat. There is no rise of infections in these 3 weeks. So if you look at the INSACOG, we have INSACOG. This is nothing but Indian SARS-CoV-2 Genomics Consortium. This is where actually whatever the samples like the COVID positives we are getting, we are sending to the INSACOG that is analyzing genomic analysis. It's doing it. So as of now, there are around 8 cases of XBB 1.5 strain. Yesterday I had seen this in one of the business standard news which has come out, showing like around 8 cases have been isolated. And BF7 around 4 cases across different parts of the world, like West Bengal, Gujarat, and Haryana, and one in Odisha. So this is what is going on right now in India. So what are the different measures that were taken by government? So basically, because of this, the possibility of surge, the fresh advisory is airports and entry points across India, they have strengthened the surveillance. And if they are detecting any positive cases, they are sending to the genomic sequence to detect whether what are the new variants that we are getting inside India. So then random test of around 2% international passengers, they are doing random sampling. So what we have to think, whether this infection will be producing a lot of a very big wave in India, like second wave, whether we have to be worried. Probably not. That's what, as of now, the speculation, because the reasons are like over 90% of Indian adult population, because of a vaccination strategy and vaccination drive, they are almost fully vaccinated, 90% of the people. And along with that, almost 1/4, that means around 25% of the people even got the booster doses. Probably, and other than that, the natural infection, because of which the possibility of production and may not be having a very big wave. And as a part of the strategy, the 27th December, Indian government center actually asked states to conduct mock drills across the country. So because of which the under the directive, the hospitals have conducted to look at the facilities, whether they are adequate, isolation wards, beds, whether oxygen facilities are correct, and what are the capacity of beds that can support ventilated patients and all. So different parts of the states, they conducted the mock drills for the like preparedness of the possibility of COVID another wave. So the hospitalizations, as I was telling, in this period of time have not risen because of these detection of XBB or BF7, probably thinking, as I was telling, because of the vaccine and prior infection, which is called hybrid immunity. And as compared to the China, where they've strictly followed zero COVID policy, and after the relaxation of the zero COVID policy, there was a surge. Probably it may not be the same to India. So the situation might, but we cannot totally rely upon that. It can change because of so many different parts of the world and so many transport can happen between countries. The possibility of rising infection cannot be ruled out totally. So that is the reason the vigilance has to be vital, and India's worry should be monitoring the new cases and identifying which variant is responsible for increased number of cases. This should be the priority. And then how to avoid infection, the measures which we have to take, as we were discussing, the first thing, important thing is getting vaccinated. Probably 1/4 of the people got the booster, probably aiming to remaining people to get the booster may help, because the new boosters which will give protection will be helping in tackling the COVID crisis. And of course, second other thing everybody knows, like wearing mask and following other all precautions, avoid huge gatherings and all will also help. I just wanted to highlight one of the study where they looked at what are the different COVID boosters, how they will be helpful. If you look at the circulating antibodies, if the variant which is currently running or just previous to that, if the booster dose which contains that variant, probably the circulating antibody production is better as compared to the original vaccine, which is an older one. But different studies, actually, if you look at this is also graph, the same thing, the boosters are more effective when they resemble the circulating variants. But I feel the circulating, getting a vaccine to the circulating variant is unrealistic, and probably it may not be possible, because that fast tracking and getting that the booster vaccine is unrealistic, I feel. But whatever the existing, the study showed that the existing, whatever the older jab is there, if you take that jab itself, that vaccine itself, I probably gives the same protection as like the current variant as it's going. And at the end, I tell that the resilience, as we had shown, we had faced very big crisis during COVID, second wave and all. We have to be resilient. Having a teamwork will help tackling whatever possible COVID wave comes. So we should be all together and working towards tackling it. Thank you. Thank you, sir.
Yeah, thank you, Kaladhar, for that overview. And you brought all the areas into one platform. So now what we have seen in the last few weeks is not just in China. We know the data or the numbers, including the cases, deaths, and hospitalization has not been open since this beginning of this COVID pandemic from the China. But we have seen a surge in other countries surrounding China, in this part of the Asia, like as you said, in Japan, South Korea, and some parts of Hong Kong. Similar way, we have seen some case rise in Western countries, including we see initial part of December in United States and then Brazil and all. Germany and France also saw some kind of surge in these cases. We may have a different reason why the surge happened in the West and why the surge happened in China and Japan. I was also going through the track records of Japan. Even Japan never had such a huge surge of cases, and even the deaths. Their highest deaths were never crossing 500-700 in a day. And first time we are seeing those numbers are touching in this surge. So, Dr. Raman Gangakhedkar, sir, welcome you on board. So the concern, the first question in everybody's mind is, in 2020 Jan, we had same kind of complacent saying this is somewhere in China. So how does it affect us? We have no cases in January, February, March, April, May, June, and in August it bursted. It bursted to October in a bad way. And those memories are not waived off many of us. So is this not just case number, the strain in the healthcare system in China, whatever information indirectly we are getting from the China or in Japan, the strain in healthcare system, the number of deaths, the number of severe cases, the number of hospitalization, the number of pharmacy requirement, the number of emergency waiting system, oxygen cylinders, this has all been under strain. Is it a concerning for us? Are we worried about that in India? What is your take on that?
I wouldn't think that we should be extremely worried with respect to whatever is happening in China. I may not fully agree to what you said, that we were caught unaware in the first wave. No, actually, lockdown as a measure helped us to ramp up every capacity, whether it is healthcare infrastructure, the ICU beds, the oxygen cylinders that we had to provide, because we shifted from the industrial oxygen to human use oxygen at that time. You look at PPE, masks, we didn't have anything. But that has helped us in the long run. The reason why I'm saying where were we complacent, complacency was there when it was just before the second wave. Because then people were not thinking in terms of getting hit by another variant so quickly. And the result was evident, because though we have good oxygen generation capacity, we had not we had allowed the industries to use that oxygen, especially these are in the steel industry, they use a lot of oxygen and things like that. So industries started using it. That's one. Second thing which we have to understand, so healthcare infrastructure, we, as of now, we are the best place when it comes to healthcare infrastructure, the diagnostic network that we have, and we have the experience as of now of the earlier outbreaks, and you have ventilators all across. Right now, you look at what's happening in China. In China, they used a vaccine which is of an efficacy which none of us can vouch for.
Yes.
If you look at their publication, they have used whole inactivated vaccine all across. They have not been able to produce mRNA vaccine. mRNA vaccine was just recently developed by them, but they have given everybody whole inactivated vaccine. Why is that a worry? That is a worry because whole inactivated vaccines that they have produced are using traditional adjuvants. Whereas if you look at even our Covaxin used adjuvant which is called as alhydroxyquin 2, which is which is something which should actually be a matter of pride for us, that this was developed by an Indian in USA. This particular novel adjuvant is known to give huge boost for immunogenicity. And that is why Covaxin was far different. And the other one that 90%, almost 90% got it from Covishield. Covishield never had an issue whatsoever. Now, if you look at their data, their data ranges from 51% to 73% if these studies, the effectiveness studies were done in different countries. But if you look at Chinese data that they have published in Lancet, if I'm not wrong, they claimed the efficacy of 95%. Actually, whoever donated vaccines or got those donated vaccines, they did not use Chinese vaccines because they dropped it. There were allegations that how could WHO also allow these vaccines to be marketed because they have poor efficacy. If you look at the upper and lower bound of confidence limits, they used to go even below 50% in certain circumstances. So they have used a poor vaccine. Now, if you have a poor vaccine, the other major issue that comes up is if you look at old age population, India has close to about 6% people who are considered as older above 65. You compare that with China, you compare that with Japan, you talked of Japanese deaths also. You will suddenly find that they have 18% population, which is in 65 plus category. So you have a deadly combination. One combination is you have a poor vaccine of lower efficacy or suspected to be of low efficacy. On top of it, you have a huge population which is vulnerable. It is 3 times higher than what you saw in India. The third thing which is also important for us to understand is they protected everybody. If you look at that entire block on Far East Asia, China, South Korea, then Japan, you talk of Hong Kong, you talk of even Thailand, they tried to follow zero COVID strategy. The result is the population is vulnerable. Large section of the population is older. They have been given poor vaccines, and on top of it, you see in China the coverage rates above 80% or 80 years of age are extremely poor for vaccine.
Yes.
Naturally, what would happen? The infection, any infection that goes in there, will have far higher numbers. Once you remove zero COVID strategy, it is very interesting to look at Chinese responses. So China, so far for 3 years, had been able to somehow manage to contain this outbreak. But suddenly, because of public pressure, despite being a communist country, despite being a dictatorial regime, they were forced to withdraw the entire thing in a very short period of time. Whereas you compare that with our lockdowns. Our lockdowns actually went on for almost a year. We used to reduce, we used to take out some of the strategies of lockdown every 1 or 2 months or 3 months. This would be allowed, this would not be allowed. And the result was we could manage to contain the population to be vulnerable at one point in time. That is another reason why healthcare infrastructure tends to get burdened. Now, is that a big worry? You will see there will be more deaths in China. Now, people could attribute it only to lower vaccine efficacy per se. Now, there could be two things which we have to consider. When we think in terms of Omicron, and when we say it is a milder infection, but you must also remember that it is not only a viral attribute, but perhaps an attribute of the vaccine that we have given. Nobody has that kind of data to dissect and say whether it was the virus which predominantly had lower virulence, or is it that because of vaccine, there was a lot of protection. But whatever it is, we were best protected. And do you expect that things should be bad? To my mind, no. The reason I'll tell you is slightly different. When it started in China, one thing which I used to keep on teaching and also telling on TV is the R0 of this particular virus, which Dr. Kaladhar has told between 15 to 18, is around 15. It is around 15 to 18. The transmission potential that the virus tends to have. Now, can this be a true estimate? Perhaps not, because if Omicron is more asymptomatic, if Omicron can be tested even at home, because they also have home-based kits now, not everybody will come forward. So it is also an underestimate. So what is importance of the same? The importance is very simple. You will find that the wave that comes up will be so sharp and reach the entire peak so rapidly, and it will suddenly start reducing. One of the predictions that I had made was the wave will subside within 6 to 8 weeks' time in China. I do not see why there should be a second wave which will be larger than first wave. To me, second wave may not come. If at all, if it comes, it will be short, very small compared to the first wave that they are seeing in China. What is also important is to understand that when the wave becomes very short, for us, whichever infection we had prior to Omicron, it used to last for about 6 months' time. Here, if it is going to last for only about 2 months' time, the virus will not be challenged as often because it will last only for two months' time. And naturally, the virus will have lesser opportunity because of higher R0 value to evolve and create those mutations, because there will be no challenge. If somebody is infected, comes home, spends about 6 hours with his family members when he doesn't know whether he is infected, so he will infect almost everybody. So where is the issue for the virus to change? So to my mind, there will be no new variant that will come. Now, if a new variant has to come, what should we be expecting? If you look at that phylogenetic tree which he showed, Omicron is far distantly placed when it comes to the other variants. The other variants, as I call them for laypersons, when I give an example, I said they are real brothers. No? If you look at Wuhan virus and Alpha, Beta, Delta, and everybody during that time, you look at Omicron. Omicron is a cousin. The distance is too far away. And if you look within Omicron, you will find there is a divergence in BA.2. There is a divergence that is occurring in BA.5. And that divergence is also so big. So what does it essentially mean? If a new variant has to come, the variant is likely to be far different. Now, should we be worried about it? To me, no. The reason is, if you actually see that we have spent 13 months after report of Omicron from South Africa. You just recall the past. Every 6 months, we used to have change in variant. We have now spent 13 months because even for evolution, the virus has to gain so much in terms of survival advantage that it has to mutate. With Omicron, we know the R0 values have increased so much now. Now, where is the scope for increasing infectiousness? No, there is nothing that it has to do. So you look at transmission efficiencies across different variants in Omicron sublineages. They don't differ so much. And some of the variants are recombinants. So if you have a recombinant, one has to remember recombination is not a planned event, not an efficient response of the virus to produce a new virus which will have better survival advantage. It is just an accidental thing. So none of these will actually be seen after a short period of time, because it doesn't give you the same survival advantage which others have. So they will disappear. It happened even in HIV. HIV also, we had so many recombinants that used to get reported, but none of them eventually survived. That part we should know. And we have to remember our advantage is we had Omicron infecting almost 100% of the population. And in Omicron, we had BA.2 and BA.5, which were predominating, though BA.5 was lesser compared to BA.2. So our people have the right kind of hybrid immunity. Nobody should expect that if will this infection get transmitted in India? Yes. If there is a newer variant, the newer variant will come no matter what we do with air travel restrictions or whatever. This is a global village, the infection will come. But what is also important is, even if this infection comes, we will not be able to document rise in new infections because people are not coming forward to test. There will be people who will just get infected. It's more of a subclinical kind of thing that will happen. Or even if somebody gets infected, the illness is for such a short duration and milder one that they will not come to the hospital. But what we have to do is keep a watch on mortality and hospitalization.
Yes.
So that surveillance has
so
to become stronger.
I think you put across all the issues in very crisp and very way, sir. See, you said ki zero tolerance or a zero COVID policy was one concern with them. Second, you said the vaccine which they took has not been properly evaluated and nobody knows its efficacy. That was always a. The elderly comorbid patients or vulnerable patients were higher in them. So these are the three important components which probably created always a prone population. And from zero COVID policy opening up at a time, not in a phase-wise manner, was another probably a kind of flare-up of all those things happened. But you made a very interesting point saying that whatever we have learned about Omicron in the last 13 months from 2021 November till now, from South Africa, that it is a milder variant which infects very rapidly but doesn't cause much of severe disease, is no more true in China. It was not the truth what happened there. We have seen more sicker patients, we have seen hospitalization, we have seen deaths. So, and you pointed out that this can be due to many other reasons which we actually faced during beta wave, delta wave, and first and second wave with vaccinations, herd immunity, natural infection, all that give. But what happened to the other countries like what we have seen in surrounding Japan? Is it the same situation? You said population is one. Is the vaccines were the same?
No, they were mRNA vaccines.
So why are now the Japan is going through this? Is it a zero COVID?
Oh, no, Japanese, acha, you are asking a little different question. No, in Japan, they had put up restrictions for tourism. No, those were lifted in the month of December 2022. Sometime, I won't remember the exact date. I think it was first week of December. They had restricted movements of international people coming into Japan. Now, if you recall, when it was Olympic, at that time, they had created tunnels, how they will be picked up and nothing would happen and things like that. But this they stopped in the month of December. So they were exposed to Omicron, number one. Now, one of the issues which we have to remember is all the new variants that tend to come, they generally generate escape mutants. Otherwise, it will not be able to survive. So even if you have taken mRNA vaccine, what will happen? Infections will occur. But it is the susceptible population which is having chronic morbidity that will succumb to it. Maybe at a lesser rate than Delta or any other thing. But in terms of absolute numbers, when you have such an old age population, the numbers tend to sound higher even for Japan. And Japan has one major problem. The major problem is older people tend to stay in those pensioners' houses. And what is also important for us to remember, Japan in urban areas has such a huge population density compared to rest of the places because it's a small island. And if I'm still not wrong, I think their population is somewhere around 10 crores or whatever in such a small place. Naturally, you will find that the infection spreads very rapidly. And the susceptible disease population is there to see increase in death rates.
Maybe. So we see now we are seeing this the B7 variant, which has been there and detected in even India and some parts of the others, almost from October of 2022. It's not a new variant for any of us. We have seen that variant being available in many of the parts of India and other countries. The same variant is creating a havoc in now the China and other parts. But in the similar way, we have seen a surge in December and in the early part of January in the West, like Brazil and United States and France and Germany also we have seen with this festival and opening up, but not the similar way of hospitalization or deaths. And it has been contributed not the B7, but the XBB variant, which has been common in the transmission. What your comment on that? Actually, what happened is people mixed those two. The cases are rising in China and surrounding, also rising in the West, which actually is a pattern which we have seen in the previous first part of this pandemic. So what is your take on that? Why it actually surged again in West? Is it because of another variant, which we generally see like any flu?
No, there could be multiple reasons. One is look at the operational reason why you would see increase in USA, France, or places where health services are provided through insurance agencies. You have system of health HMOs that they call in US. You don't have access to things for even testing if you don't go to the hospitals. Now here, if you compare that with our population, you have a public-private model. Anybody could walk into pharmacy and without telling, they may purchase diagnostic kits. So the numbers that you actually estimate there and numbers that you see in India are going to be drastically different. Does this mean that if we had lower numbers that were being reported by the government, is it a actual reflection of the caseload? Absolutely not. They cannot be trusted, mainly because people did not come. What would you do? It was not the story in most of these developed countries. If you have to get even a small antibiotic tablet, and they had at that time different respiratory pathogens which were also infecting them.
Yes.
Whether it was RSV, whether it was influenza. And that forced them to go to the hospitals to test. So even if you had, let's say, dual infection of influenza plus COVID-19, COVID-19 would be picked up. No, but the issue is it was forcing them to go because there the fear was influenza could kill me. You could have RSV. RSV can be a problem subsequently. So this actually was one of the main operational reasons that tend to occur. Second issue is with the virus. The virus, as we said, when it mutates, it tends to see that it is offered survival advantage. So the survival advantage that it tries to look for is transmission efficiency as of now. Now, the second issue that we have to remember that if there is an occurrence of a new variant that tends to come, you will find that variant will always infect others, mainly because it has those escape mutations that would be associated. If you look at number of mutations and try to compare these mutations with all the new variants that have come up, there are 21 different sites which are most important where mutations are occurring. Now, what is happening is in these different variants, some of them would have different permutation combinations. So we do not know whether they are stabilizing the transmission efficiency or adding to the transmission efficiency. But somebody may have from A to Z, somebody may have from A to C, somebody may have C to D or whatever combinations that could occur. These are only 21 sites so far. Now, what is actually happening? This is called as convergent evolution in virus evolution. Now, convergent evolution is the variants may come from different lineages, but finally they try to go for the same objective of survival advantage where the transmission efficiency is getting tweaked. All of them are competing with one another. Who can infect more people at one point in time? That's one thing. So if you look at the society, if you try and see the American data or whichever country's data, you will find they would say, I have 3% of X kind of a variant, 7% of Y kind of variant, and the list will keep on going. Because in convergent evolution, different types of variants within Omicron lineage would be found at this juncture. Now, would they predominate? For predominance, it must have, like we call it, statistically significant survival advantage of transmission efficiency, which we don't know. Third thing, if you look at US data, I wish I could have shown some slides. No? If you look at US and different states, what happens in those states? Each state has differences in proportions for these variants. Why is this happening? This is also happening because a variant which has a very high transmission efficiency will depend in local communities which are small, just for introducing one kind of a variant. If we assume that in a place like, let's say, some small village in US, one person who comes with a variant Y, everybody in the village will get Y because it is spreading rapidly. And then you look at the transmission dynamics and you try to actually make out what component of that transmission dynamics is related to introduction of infection, or what component is actually because of relative benefits that this virus tends to confer. We have no idea. So trying to draw inferences from these variants as of now in US or other places is not going to be so easy, because you have a partially protected population because of vaccines, and you have the transmission dynamics when you open up, people for movement outside, people not having COVID fatigue. It's very difficult to say that a particular strain is the most important cause. It may just be a reflection of how big is the size. As you say, if it was BQ1, if BQ1 is circulating, it may be introduced in a place with some name US. Let's say in Baltimore it was introduced. You will find in Baltimore that a large proportion of them will carry BQ1. Now, what do we infer from that?
Sir, we will go to simple questions, which there are a lot of audience on, sir. Will we, as a country in India, will face a wave? One more wave? Yes, sir.
Even if, the answer is very simple. Even if a wave will come, it will not be documented, because you should expect that the transmission efficiency will be high. People may not come forward to test because of milder symptoms. So wave, whether it can come, yes, it can come. But will it make impact on healthcare infrastructure is more important rather than number of infections. So we will not see a wave, but perhaps wave will be asymptomatic or subclinical. It may just occur. That's about
So
it.
we may see a rise in infection rate. It may be asymptomatic. It may be some milder symptoms. There may be a surge in cases somewhere or here, but we may not see a impact on healthcare system.
No.
So that's what we were trying to hear. So there were questions. So right now we need, probably the answer is we may see new variants, we may see new cases on and off, we may come across, but what healthcare system is going through in China or the closer countries which has actually followed very strict, stringent zero COVID policy may not be the same scenario here at this point of time. Second, so there were questions related to vaccines. So we all saw that there were 2 vaccines which were given a month apart initially and followed by a precautionary dose. Now, with the current news, there were a lot of concerns and questions related because the last booster dose, many of us or across the country, at least a 1/4 population, which has been taken as a year back. Do we need any add-on booster doses at this point of time is a question which has been surging up everywhere.
To now, I don't know who all are seeing, but this is a matter of science. I would not hesitate to make some statement. If you actually see the science, no, science part of vaccine, the data that we had, not only in India, you look at whether it was mRNA vaccines or Covishield, all of us also remember that Covishield, when it got approval there was a large significant population which had received half the dose, no, of the vaccine. No. Now, the rigor of science is missing. No. And naturally, now on, there will be worries of what could be the adverse events that we may face. Now, given that, you have to also look at one aspect. This is my personal thought process. Not because now I'm retired, I can't do any more experiments of any kind. But the reality is, if you want to block the virus from infecting you, you must have strong mucosal immunity, because you can't have high neutralizing antibody titers to be protecting you, because they need to be high at the time when you are exposed. You will never get them because vaccine-induced immunity, it's a B cell response. See, it will always be waning after a provision of vaccine or infection. So you will not be protected as much against new infection. But when it comes to protection from severe disease and death, why is it occurring? It is because of T cell response. The virus may enter inside, but as it stimulates T cells will mount the neutralizing antibodies very rapidly. So T cell response is preserved. No? The reason why I'm saying this. No, so do I need a fourth dose? No, I will not advise people to take fourth dose. Unless there is a proven efficacy of the nasal vaccine, which has been introduced by Bharat Biotech.
Yes.
The reason why I am questioning that is simple. Their phase 3 trial is yet to be completed. Look at their phase 2 data. They have given the data of neutralizing antibody titers. Here, this vaccine actually should provide you mucosal immunity in the nose and in the throat. So if you have to say, even based on immunogenicity, you should have data that comes from SIGA levels. No, secretory IgA levels have to be actually used for convincing them. If you look at the global data, globally there are 10 different nasal vaccines, and so far none of them have clicked. Now, I would say we should wait for some time until they produce or document anything which could be of use. If we can interpret that mucosal immunity really improves, then in those cases, one dose of mucosal immunity will perhaps protect us for a very long period of time. We need not worry. But the second issue that you also need to remember, you cannot base that observation on neutralizing antibody titers, because whoever you give this vaccine now, majority had been infected by Omicron. Now, if I provide a vaccine which is of lower efficacy, let's assume that it doesn't have good efficacy. Even a small amount can trigger T cell responses. The T cell response will be mounted, you will find high neutralizing antibody titers. So documentation of SIGA related titers is extremely important before we just decide whether I should go for nasal vaccine. And as I said, it is time that we need to be cautious, because newer and newer reports of adverse events will keep on coming now, as the entire thing will go for a better scrutiny as we have passed 3 years now. So you should be careful. Unnecessary fourth dose to my mind, it is not required.
So at this point of time, I think the only precautionary third dose is advised. Those who has not
Bas,
taken
ba-
and in probably the prone population can take, but those who have already completed precautionary dose, no more doses at this point of time are required with that.
Yeah.
And then there are questions which you answered already, sir, related to the live nasal vaccines, which has been on limelight. So if they proven to be efficacious, which can give you immunity to the infections from a mucosal level, which we are talking about, may be a phenomenon in the future, for which we have to wait for further confirmation and availability. So
No,
with this,
there is an interesting fact. If you actually look at Covaxin and compare that with the new nasal vaccine, you will find the nasal vaccine is using a different virus. It is BBV 152 versus BBV 1.54. So you need to be, I mean, from a science perspective, this is a new vaccine. Secondly, you have adenovirus 36, which has been used here as a vector. Whereas you see the CADOX one that is Covishield one, is using a different vaccine, different virus, which is there with our own Covishield that was used earlier. But their vaccine has also failed. Second thing which we have to question is when you are using chimpanzee adenovector virus, we were using it for a different reason when it came to intramuscular shots. But now here, when I'm going to produce an infection using chimpanzee's adenovirus vector, I need to be sure that each one of them have the same kind of capability to infect human beings. Because these, why do we give it in a vector? Because these adenoviruses will go in the body and will try to multiply and then infect that individual so that the process kicks on. But that we have no idea. No, that's why to me this is a evolving science. So we should look for evidences to come and then decide what we want to do.
there is a pediatric population, sir, which has been not vaccinated, and we have seen some asymptomatic milder cases, not many sicker group of patients. What is your take on their vaccination status right now with current prevailing of new variants, new infections?
No, I would not worry about children. No, not at all. Because their mucosal immunity continues to be higher. If you look at a recent paper been published from US somewhere, what they are saying is the nasal secretions that we produce, they tend to be the most important reason for protecting against colds, the common cold that may occur. And that is the main reason why I think that paper is also published in a very good journal, Science or Nature. I don't exactly remember right now. Now, what does it essentially mean? Any child who tends to get repeated infection will also provoke innate immunity to start working against those infections. That's why in children, none of these have been so easily creating major problems so far.
Yeah. So what is the currently the ICMR Ministry of Health are now planning and preparing? We have seen some noise during this last part of the December. So even though we are all having some backdrop idea that we had a hybrid kind of immunity, both with proven vaccination, also some kind of natural herd immunity. But where are we? How are we preparing?
No, we are very well prepared. So the mock drill that they did was perhaps the best thing that they could try. Because in India, things can be purchased, people can be placed, and then none of them, people change, the machines tend to stop working because you didn't have so much of caseload. But that mock drill has been done. So essentially, if there is any risk because of severe increase in severity, that perhaps is not likely to affect us. Second thing, what they have done is they have intensified surveillance, which to my mind, I have told them that perhaps this may not be the best possible way because you spend more money and nothing comes out of it. But ideally, what you would like to do is do Suez surveillance. And in Suez surveillance, because each sample that you test in a large area where perhaps you are looking at hospital deaths have increased from a certain people coming from a certain geographic area, and they were
A
found to
cluster,
have
you mean to say a particular cluster or a particular geographically, if there is a documented evidence of having a higher mortality, sicker patients, admissions. So
Yeah.
test their variants rather than,
That's it. That is Suez sample. So the Suez sample is representative. Suez sample is ये टॉयलेट से जो पानी निकलता है ना,
हाँ,
उसको टेस्ट करना है, वो नाले में जाता है, so it will represent that entire region. So you do one test, and in one test, if you find some new mutant,
variants.
then it is worth going back to the population. If it is an older one, then you don't care about it. But in one test, you will know. Same I said, if you don't believe China, then, or let's say any other country, what do? Instead of testing each individual, you test the Suez sample in the flight itself. So one test will tell you about everybody who is positive and what have they got, different variants. Instead of testing all those who come out as positive and submitting those samples for genomic surveillance. And the last thing which I would say is we have experience now of managing, and most importantly, even Paxlovid from our country has been approved. In Hyderabad, you have Hitro. Hitro has got WHO pre-qualification approval even for Paxlovid. So should we be very much worried as of now? No. The
There
only
is a
worry
question, there is also a question from some audience that will Paxlovid works with all these variants. Do we really need it at these variants?
absolutely, unless the person is high risk.
Thick and high risk.
If the person is high risk, you may use Paxlovid. But the problem with Paxlovid is China is using Paxlovid now. And I'm a little concerned because if you use Paxlovid, at the end of 5 days of treatment, there are certain sites where in the Empro region which will have resistance mutations at the end of five days itself. How it is going to impact the virus evolution, is that going to impact human beings, is a question which nobody has been able to answer because this is a new drug. It has just started off recent. So we'll have to keep a watch on it. At its worst, one worry that I would have, Paxlovid may not remain an effective kind of a drug because you find that close to about 5 to 10% of the people who have taken this particular drug, they tend to go for a rebound. Now, which essentially it means is the drug is not so powerful as we think. Resistance can develop in those circumstances, but we will have to keep a watch on what is happening rather than panicking at this point in time or even saying no to Paxlovid.
In any possibility of we going into again restriction if we get into a surge of cases?
Absolutely not.
No.
Even China could not tolerate. The industrial impact is so huge that Chinese had to take the risk.
COVID appropriate behaviors will still be a standard, and will it help us? One side we are saying avoid zero COVID tolerance. The other side we are saying infect yourself during the milder variant. The COVID appropriate behaviors, using masks, social distancing, hand hygiene, avoiding gatherings.
Hand hygiene is useless. That has been amply proven. No? This is an airborne infection. Actually, the research related to hand hygiene as a mode of transmission was perhaps one of the weaknesses of COVID time research.
Right.
People flooded the streets with disinfectants.
Yes.
They were using like crazy. And then at the end of it, you know that it doesn't make any sense. So there is no point in that hand hygiene. Second thing is, I would wait till the end of February. No, till the end of February, all those who are at least susceptible, must, those who are older, having chronic morbidities, to try to avoid infection by using masks, by the traditional COVID appropriate behavior related settings. That is, if you are in closed spaces, crowded places, and where poor ventilation tends to exist. But one of the most important things which I would always suggest is, at least at the end of COVID outbreak, the parents of the children must learn one thing. If my child is sick, has cough and cold, I will not send that child to school, because the entire outbreak of cough and cold that tends to occur in school should be avoided. It is, no infection is likely to be healthy the way we tend to think. Asymptomatic doesn't necessarily mean, or a mild symptom doesn't necessarily mean there will be no impact on my health when I grow up. The best is, at least they should learn that for a sick child, please don't send the child to the school so that other children don't get infected. It is useful not only for COVID, but all other respiratory infections that tend to occur in childhood per se. If we would have had learned this, and the same thing is followed by adults, even at households, it would make such a huge difference. We think that cold is not a major, cough and cold is not a major infection to worry about as Indians. वो तो होता रहता बोलते हैं, लेकिन वो होता रहता नहीं है. उसकी वजह से अगर एक दिन भी हम छुट्टी लेते हैं काम से, तो look at the amount of gain that we would have in economics, because people will not be required to remain absent, and that would make a lot of difference in economy.
True. So any comments from Kaladhar from your side on your overview? You had actually spent good time on reviewing this wave in China and across.
Yeah, sir. So as Dr. Raman sir said, I think it doesn't look like it's going to be a big surge or a big wave in India. So regarding, as we were discussing regarding Paxlovid, probably I think there is data which will work, Nirmatrelvir plus Ritonavir. But monoclonal antibodies, because of evasion of immune response, probably they will not work across different strains which are there right now, sir. But yeah, I feel that mostly if maybe if the wave comes also, it may be a bit of hospitalization, especially the patients who are at risk, like more than 65 years, having comorbids, immunosuppressed patients, and like more than 50 years with multiple other comorbids. These are the patients I feel at risk. Probably if there is a surge of infection, they may get hospitalized. As we had seen during Omicron, especially, they got admitted because of non-COVID illness. The underlying, suppose a patient having a diabetes, he landed up in diabetic ketoacidosis, something like that. Probably the underlying condition may flare up because of the COVID infection, probably.
You have seen just a coincidental co-finding of a Omicron being tested positive in those. As Dr. Raman Gangakhedkar also told ki, why there is a surge in cases in the West is possibly we have seen a winter and a influenza and RSV season, where there are more number of cases of fever, cold, cough, and they went for a testing. Earlier, milder variant, they were at home. So we never knew that there was a number of so many COVID cases. During this surge, there were cases where there is influenza positive. Along with that, there was COVID positive. Some of were influenza negative, COVID positive. So the number went up because these patients attended to the clinics or hospitals or OPD. And there was also a trend of having three of these viruses having three waves, like three viruses creating little rise in surge of those common colds and fever. So you actually gave us through the whole overview, sir, and thank you, so kind of you in giving that overview. So you made very clear that at this point of time, with the current wave going on or current surge going in China, may not be a major threat to us because we have gone through 2-3 waves with some kind of a good natural herd immunity and a very effective vaccination schedule. And those who actually gone through the 2 regular vaccines followed by a precautionary dose may not need to worry and wait for any further booster doses. Those who have not gone through the precautionary dose or a booster doses should go through the precautionary dose of booster dose right now. And in the pediatric population, those who are actually under the cover of vaccination can go through the vaccination. But Dr. Raman sir feels that the pediatric population do have their immunity, which may protect them. So we need to worry about their precautionary doses or their doses at this point of time. And if at all, we may see a surge of cases. Those cases may go unnoticed because we may not test them. They may be milder. We will not find a situation where our hospitals will go into a strain, or a healthcare system will go into a strain, or the severity will go into such a deadly state, except those situations where the case severity will go up or hospital will go into a strain. Probably no form of restriction or no form of lockdowns will further come. That's what we wish and pray. And with this, I think we hope and pray that because of the whole hard work of not only just the clinicians or many departments, including ICMR and all of your contribution during that period, we hope we will sail through this pandemic in a healthier way. So that's the message which Dr. Raman Gangakhedkar sir wanted to give. Thank you, sir. Any final comments to conclude the session?
Now, what we should be worried about is perhaps COVID phobia rising in some people. We need to have a balanced communication. There will be a small proportion of people who will overreact to this, like we used to have AIDS phobia. But there has to be a balanced communication with population when we speak about them in public domain. They may just go for COVID inappropriate behaviors. Because if you just say, oh, nothing is going to happen, don't worry. So we have to maintain that balance between creating phobia and a balanced response to use of COVID appropriate behavior.
I think you want a very important component saying that those who are at high risk, elderly population, those who are actually comorbids, those who can actually catch hold of a severe form of disease because of their underlying condition should avoid large gatherings right now, use masks when they're in a closed space, avoid as many as possible of those gatherings, and the rest all can use the probably droplet precautionary measures, including the distancing and masks, and hand hygiene may not have a role to play at this point of time, being this a droplet and inborn. I think that message also he made it very clear. I thank you, sir, for being here and sharing your wisdom and knowledge. I thank Kaladhar in bringing that overview. I thank all the participants who are there with us and creating. So I thank all the participants and conclude the session. Thank you all, sir.
Thank you, sir.